Leading on to the next session now, which we're building onto, it's an update from the National Haemoglobinopathy Panel with Professor Baba Inusa. Just a bit of a background on Professor Inusa. He is a consultant hematologist and a professor of pediatric hematology at King's College Hospital. He's lead consultant of pediatric hemoglobinopathies at Evelina Children's Hospital and Guy's and St Thomas's Hospital in London. Professor Inusa is a specialist in sickle cell and thalassemia and chairs the National Haemoglobinopathy Panel. He works tirelessly for people with sickle cell, thalassemia, and other inherited blood disorders, and is involved in the development of national standards of care for sickle cell. Professor Inusa has been a tremendous support of the years, guiding our team on many different aspects of care and supporting all of our thalassemia initiative and events. I would just like to say a big thank you to Professor Inusa for always being in our corner, ensuring thalassemia is well represented on every platform. We're extremely grateful to have you here with us today. And without further delay, I'm now going to hand it over to Professor Inusa for your presentation.
Thank you. So if I do cut out, I will try and link up to the mobile phone, but thank you for the opportunity to share with you and just really an update about what is happening with NHP, the National Haemoglobinopathy Panel, and also its work, and to thank the UKTS in particular for contributing quite significantly to the work. And actually, some of the leadership have been coming from you, actually, and we have benefited from your hard work. We have benefited from your website and also your communication. In fact, some of our videos, you've transferred them into YouTube. So thank you for all the work you've been doing. I think it's a privilege to really see and listen to some of the speakers. I just listened to the one by Chineze, and that was very, very interesting. Yeah, so rather than saying you or saying me, so yes, we'll try and do that so that people don't get upset with us. And thank you for the update on your work as well. And I've just found out that yes, your website also has just changed. So well done, excellent. So I will just be very brief because I don't have very too much to say, but I just wanted to highlight the role of the NHP, and the NHP working very closely with the HCC being the coordinating centers, and then the NHP being the National Haemoglobinopathy Panel. And also down the stream will be especially hemoglobin treatment centers. And so I will just do a bit of a reasoning. Why did they actually have to do this? How did they have to actually review the services? And this actually was a very prolonged program that actually involved significant people in terms of consultations and communications, and to make sure that, yes, it actually answers to what patients are asking for. Obviously, it's not going to be an answer to everything, but actually it's going to be a way to actually move forward. And so prior to this, prior to 2019, centers just designate themselves as specialists, and they do the work as local or specialists. And then the designing really wasn't kind of taking into consideration some core locations and everything. Looking at the adjacent maps, identify the location of the current. So currently there are 10 HCC for sickle cell disease and 4 HCCs for thalassemia and 23 specialty treatment centers. And this process actually became effective for the SHTs, actually became effective in March 2019. And then NHP and HCC was formalized October 2019. And so the rationale for the review was because of poor patient experience. Again, you actually believe and know that this is not a past question. This is still an ongoing issue. But again, the question is, are we moving in the right direction, or are we listening? And what about blood transfusion? And do people have access to do transfusions or programs when they actually want to? Particularly when you think about children, parents don't really want their children to miss school. So really getting this available out of hours or maybe during the weekends actually can be something very important. And so the other things are staffing, and staffing remains an issue, and particularly people like me are getting to retirement and are not going to replace people to really kind of continue the service. And they will have a full complement of staff, particularly in terms of other specialties, not just nurses and doctors. And I know psychology remains an issue that is very good in some centers, but actually something that needs to continue to grow. But thanks to the patient societies, your impact and input to patients at the local level is actually very key. And so performance in terms of quality being variable, obviously where you're located sometimes might determine when you get your medications. And one of the other thing about the activity and cost was that some of the centers are actually very small, but because they had a way of claiming for their services, they actually were probably better funded than some of the bigger centers. And also because of the way the patient's pathway was going, they go straight into like open access and other things, although very low by some patients, also maybe slightly overbearing and not allow proper assessment of some of the patients. And the configuration, again, we're making some progress, but it's trying to make sure that centers are actually linked in a way that they know who is the person that actually can report to. So, so it was to undertake a comprehensive assessment of contracting arrangements. Again, I don't understand that much, but actually something that would make sure that whatever services are provided are paid for appropriately, and to develop a future state that delivers equity of access. So if you need bone marrow transplantation, you don't have to be in point A to get that. If you need luspatercept, yeah, if it's available, then you will not be in one center in the other. And also, again, thank the UKTS, particularly for the PIPS application, which you really have been leading us. You've been leading the NHP as well, because we just follow your lead. And in terms of data collection and data management, thanks to FARA and the NHR, we're actually going to work to make sure that we get a lot of data that shows the activity, that shows the morbidity, and actually where necessary to see what can be done to actually try and improve outcomes for patients. So some of the issues and root causes analysis involve all of this aspect, which I've mentioned: access to drugs, service. And so, for example, people will say, okay, what are some of the issues that why drug varies from one? Is there a lack of a national protocol or audit, and patients are treated by clinicians of very varied experience and expertise, which is very true. And commissioning and contracting actually vary across the areas as well and the regions. So there are a number of, if you look at every box, there is something that actually people identify. So this consultation was really involved patients, involved staff, involves commissioners. So the answers and the comments actually were very comprehensive and very educative, and showing that we need more education and then more access. We also need to make sure that there is a greater communication between the patients and their users, but also that we're able to actually work directly with commissioners to actually be able to influence some of the actions. So one of the things that we, and I'll come to some of the reasons why the NHP, which essentially is referred to as an MDT, the reason why it was set up, and the functions of the SHTs. So what was the roadmap? And the roadmap, when the program was started, reviewing services, and the aim was to actually have contracts out by May 2019, but at least we just missed that, but actually ended up with contract at October 2019. And so that was some significant achievement, but actually it took a very long pathway and very convoluted, but I believe that maybe a possibility that are actually possibility of changes. So this is how the arrangement goes. The NHP, the panel, an overarching kind of relationship with the HCCs, the coordinating centers, the specialty treatment center, and local treatment centers. And so you could see now that if there are cases that are very complex that have been dealt with at the HCC level, then they bring them to the NHP to actually have some further discussion. And subsequently, we anticipate that at some point in time, treatment actually would also be determined by the NHP. What treatment would be that? Things like these high-cost drugs, if they are approved by the moment, rituximab and eculizumab, actually you have to put some of the treatment that they use for blood transfusion. People are reacting to transfusions. So those medications, we have to take note of it and know exactly how much is it that, how many have they used, in order to understand the cost and inform the NHSE. So the NHSE want to know the cost in order to prepare and plan for the future. So, so a number of things will be happening. So these are the various HCCs, obviously the North, which include Manchester and Yorkshire, and so we have Nandini there and Joe Keshi, who are actually and Joe Sharif. Nandini is the thalassemia lead, and then we have the Midland, which is based in Birmingham, and then we have the London and Southeast, which is the Royal London, actually, which includes our own area here in the Southeast London and Southeast, and the London South Central and Southwest, which is UCL, which Emma Drasser is the lead there. So these centers are actually very important. So the HCC, the role of the HCC, they lead regional multidisciplinary meetings, MDT otherwise referred to, and they look at cases including sickle cell, thalassemia, and rare anemias, those three major conditions, to see what are some of the common presentations and the common problems. And we've been collecting the data to see, so each side will collect their data, and actually if the case need to be referred to the NHP, they'll refer the case to the NHP, and the consultant that takes the case will then discuss with the NHP. So referrals to the NHP is mainly through the HCCs, but also it could be through the specialty treatment centers. But we try to limit to make sure that a referral to come to NHP needs to have gone through the HCC. It's not mandatory, but it's very helpful to do that. And then the functions, the clinical function, ensure effective running of the clinical pathways within the network. Obviously, when we think about the North Central London, and includes even East Anglia and other things. So you could see a bit of tendency for a variation. So there's need for communication, very effective communication. There's a need to also ensure a training. And so I'll come there. So service improvement, conduct regular audits and benchmarking, and ensure feedback from patients, and in order to inform the service improvement, and all of this will be gathered together, and then they'll report them so that they can look at together. Obviously, they're not made to report this to the NHP, but this will actually go through the CRG because it's a commissioning arrangement. And while you have identified some challenges in terms of teaching, learning, you actually will then have to, in terms of education, we have to organize educational program. One of the advantages since starting the NHP is that we're able to actually share lessons that we learn together. We're also able to invite other centers to actually link up with another training in a different center. So the training is supposed to be more comprehensive. I think one of the things that UKTS did, particularly during the peak period of the COVID pandemic, was the fact that you had road shows. You had this opportunity to really go into patients and talk to them and get their questions. And these questions are still varied and obviously still very valid as well, particularly when you think about even the vaccine issues and challenges. These are also issues that the society, UKTS actually really have significant contribution to. And so the actual development of the pathways has continued, and they'll work with the NHP to gain the expertise of clinicians from area. And so what happens is that if there's an immediate case that happens within the HCC, they'll actually communicate with the NHP, and we can easily create and call an emergency, which we refer to as email MDT, and discuss the case and offer some solutions. So there is a significant patient input that actually the NHP actually would have in terms of contributing to the role. So established as act as a national point of referral and advice on new treatments, including novel medicine, gene therapy, and bone marrow transplantation. Obviously, you know, the development in terms of adult bone marrow transplant for sickle cell disease. At the moment, the issue is still yet being discussed for the thalassemia, but to make all of these very comprehensive, but also make them uniform actually is important. And so during the panel, we discuss individual cases, and then we can offer advice to the centers. And every HCC is involved. Every HCC has a contribution, and also are able to make a significant impact on the running of the service. So the frequency of meeting dependent on the demand. So we do have so there are, if you think about the structure, that is both a business structure and an MDT. So the business structure, which the UKTS present, as participate, is to allow us to look at all the functioning and to see some contribution and say, okay, what are the various things that we need to do to actually improve the working of the NHP for the benefit of patients. So having the UKTS speaks for thalassemia, and SC, Sickle Cell Society for sickle cell disease, rare anemias also for rare anemia, so that there is a kind of an equality that to make sure that the needs and the issues from other sides are actually not ignored. And so the NHP, myself as the chair and the deputy chair is John Porter, who most of you would know because he did a lot with thalassemia, and also have the supporting officer and Shen Nagel, and also and then we have actually got people to actually have special leads in some of these areas, not necessarily that others are not leading, but actually so that somebody can coordinate. So that we have somebody can coordinate thalassemia. We have somebody who has volunteered to do that. We also have somebody who coordinate sickle cell disease, and also so in each HCC we have a representation. We have a TCD. We also have so the operations of the NHP in terms of education. One of the challenges that how do we offer education and yet not cause some kind of consternation by having some conflicts with other people who are doing some educational activity? That's no issue, because at the moment we are very clear that we have a lot of lessons that we learn from the national MDT, and we want to actually discuss this in more openly. And this will be a forum that actually people will be able to be invited to attend. So first of all, we want to even try to agree some pathway in terms of bone marrow transplantation, who has access to what. And also we get an update again about a new therapy. So a list of centers providing innovative therapies, and then coordinating peer. So we'll work with a peer review system, basically because peer review is a whole big quango that is very difficult to just run it from one. So that's why the peer review will report monthly directly to and the clinical reference group, which again the Thalassemia Society is part of. And we try to work on terms of research and new therapies. So in the initial period of the MDT, this is an idea about the number of patients that we've already gone beyond this. But if you look for the initial months, we have this distribution of patients that were referred to the MDT, and they were referred to for different reasons. Thalassemia at the initial period was 3, sickle cell 9, and the others were 2. But again, that's way above ahead of this area. So that data will be reported later on. So there are still issues in terms of clarification. Who should be referred for gene therapy, for bone marrow transplantation? And this is being discussed extensively. Again, we're working with transplant specialists so that exactly we can develop something that is very clear for adults. Obviously, in children, we can offer any child, but we want to make sure that before you offer bone marrow transplantation, it's good to discuss it at the NHP MDT. And so again, we're thinking about transplantation in various conditions in thalassemia and sickle cell disease. Don't take this as gospel truth, because this is discussion, a lot of discussions, a lot of uncertainty, but we are really having some active discussion, and I know we are actually aiming to have a whole forum whereby we can discuss this as a group and actually come to some kind of agreement together with the bone marrow transplant experts, so that we have something that actually meets the needs and the demands of each side. So so what happened is that, so if you think about the role, there are various other bodies that are very relevant to the work of the NHP. The UK Forum Hemoglobin Disorders actually is a very significant body that has been working very long term and working very closely with the societies. And I think the role of UK Forum in terms of oversight and peer review is actually very important. They all contribute to the NHP. And obviously, we report to the NHSE. We do that through the CRG, and we're going to be reporting our annual review, annual report soon. And there are some reasons why it has been delayed a bit. And also, we also kind of relate with the HCCs and also the the SHT as well. So SHT being the specialty treatment center, basically like our hospital or many other hospitals. These are the specialty treatment center. So we need to work together as a coordinating center. So we, Gaza, St. Moses, Evelina, and Kings work as one. In order to actually meet the areas and the need of patients in Southeast and East and South London. But actually, we are part of the HCC of Opol Telva and Banukaya. So we report to them in terms of thalassemia management, and we present to them if we have complicated patients and we need some advice. We also report to them some of the data that actually we are acquiring from our patients. So it's to allow and improve communication between the different group. And so really in terms of bone marrow transplantation, I don't want to say too much because there's a lot of discussion going on in terms of, so this is basically in terms of the referral pathway. And then so I would like to welcome comments, but I also want to state that since starting the NHP, it has become very clear that other people really want to follow the pattern. So we have people from Ireland, people from Scotland, and Wales is not a part of it, but also they have really tried to come to work with us. So really working together with them has been very important. And because they found it useful, they actually refer patients to us and we discuss their patients as well. So just kind of in summary is that the NHP has two functions. One is business, one is MDT or multidisciplinary team meeting, of discussion of patients' issues. And this MDT, we have a core team, we have an email team, we have observer teams. So the core team is selected from all the HCCs to make sure also there's a representation from nurses, from psychologists, from all therapies that are actually involved in the management of patients. And so that when we present these patients, then actually they give you some significant contribution and oversight and overview or maybe opinion that actually you may not have thought about. So I think it's important to have everybody engaged. Unfortunately, the MDT, because it's confidentiality and patient discussion, we do not have non-clinicians on board of that particular one. But the one in the business panel, we have the non-clinical clinicians really involved in actually directing the services. So we'll also be reporting our outcomes and our annual report once we discuss it with the host, because the host for NHP is the King's College Hospital, which combines GHCT as well. HCC, that's the host of the NHP, and that's why I have the opportunity to actually be the chair in the first set of the NHP. So I want to say thank you for the opportunity. I hope you are hearing me, because you never know about this internet. Sometimes you're talking, nobody's hearing you.
That was fantastic. Thank you very much, Professor Inusa. That was great. We did hear you loud and clear. We really do appreciate that. Fantastic presentation. Thank you very much for going into that and for taking your time out this Sunday as well. Thank you very much.
You.
And for your support as well, going all the way back and going forward. Thank you.
Okay, thank you.
Thank you very much.